Hi, good morning or good afternoon, everyone, depending on where you are. My name is Tara Kalk. I'm the project coordinator for the Southeast Mental Health Technology Transfer Center, or MHTTC for short, and specifically the School Mental Health Initiative. We are very excited to kick off part one of our learning series on supporting the mental health of students with intellectual and developmental disabilities. If you have audio or technical issues during the session, the chat box is open for you to communicate with our team so we can assist you. Also, if you have any links to resources that you'd like to share with other attendees or us during the session, feel free to use the chat box for that. And of course, you can ask questions for our presenter. And we ask that you use the chat box during the session for questions, and we will have some time at the end of the session for questions and answers where we welcome you to take your mute off and ask aloud or ask in the chat box. But for now, we ask that you keep yourself muted throughout this session. And we do have a quick disclaimer. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. All right, and a quick introduction for those of you who may not be familiar with the Southeast MHTTC. So today's session is brought to you by the Southeast MHTTC School Mental Health Initiative. We are located in Atlanta, Georgia at the Emory University Rollins School of Public Health. And we are proud to serve the 8 states in HHS Region 4 that you see pictured here in the blue map. Our center includes faculty and staff with expertise in public health programs, finance, policy, and health systems. And this provides us with a unique lens through which we can address mental health priorities in our region. The goal of our center is to accelerate the adoption of evidence-based mental health programs and practices by providing training and technical assistance to Region 4. And now I would like to introduce our speaker, Dr. Catherine Pickard. So she received her doctoral in clinical psychology from Michigan State University and completed a 2-year postdoctoral fellowship at JFK Partners at the University of Colorado School of Medicine. Her primary research interest is the translation of evidence-based treatments into community systems that are naturally positioned to serve children with autism spectrum disorders, or ASD, and developmental delays. Clinically, Dr. Pickard is a licensed psychologist and has a strong background in supporting individuals with ASD and other developmental disabilities across the lifespan. She holds specific expertise in intervention for young children, as well as cognitive behavioral therapy for youth with ASD and co-occurring anxiety. And now I'm going to hand it off to you, Dr. Pickard.
Great. Thank you so much, Tara. I've been looking forward to giving this talk for a while now, especially as someone who's relatively new to the Southeast. I moved to Atlanta about a year ago. So I guess maybe maybe that makes me not so new anymore. But I'm excited to be here and appreciate you all being here, especially with it being the start of the school year and everything going on in the world and with COVID. So thank you. Just a few housekeeping things before we get started today. So to make this presentation as interactive as possible, we will be using polling questions. And so you will see those pop up from time to time. And those are really to get your thoughts on either kind of how you view mental health and students with IDD or barriers that you see to serving this population. So you'll see those. The challenge with polling is that there's not an open-ended response option. And so if there are, like Tara said, if there are comments that you would like to share, feel free to use the chat box. And same with questions. If there are questions, pop them in there. I'll do my best to be monitoring them throughout the course of the presentation and may take some during it, but may hold others till the end. So So yes, so with that, let's get started. And so like Tara mentioned, this is the first part of a series on how to support the mental health of students with intellectual and developmental disabilities, or IDDs. And to me, this is an important topic, and one that I think for various reasons at times is overlooked. And so the first part today is really designed to identify students with IDD, and especially the mental health challenges that these students experience. And so by the end of the webinar, participants will be able to identify students with IDD, to identify the mental health challenges in students with IDD at schools, and to describe the risk factors that really kind of make students with IDD more susceptible to having mental health challenges. Now, I will say these are both fairly broad concepts, right, or topics, IDD and mental health. Both of them are umbrella terms that encompass kind of different things. And so when we talk about mental health and IDD today, we'll start off broad, and then from there narrow in on specifically autism spectrum disorder, in mental health, and then even from there, autism spectrum disorder and some examples tied to anxiety. So you'll see that funneling that will happen. All right, so here's the first polling series, and this is really to get to know the audience, to get to know you, and to understand what experience you're coming to this presentation with, and in what capacity you support students with IDD. So feel free to take these, kind of flip through these questions, and when we're done, I will share them out so y'all can see. Awesome. I'll give you about 10 or 15 more seconds, and then I'll share those out with y'all. All right, so I'm going to end the poll really quickly, and I'm going to share them out just so you have a sense of who else is on this webinar. So the first question was, what is your professional role? And not surprising, many of you are sharing that you serve kind of in a mental health capacity, whether that be counselor, social worker, psychologist, lots of others. And I see some folks are popping the other into the chat box. How much of your professional time do you spend working with students with IDD? Majority of you are saying less than half the time, but really it seems like there's actually a good amount of variability in how much time you're working with these students. How much of your professional time do you spend supporting the behavior and or mental health needs of students with IDD? And for this specific question, again, lots of different experience, but it looks like the majority of folks on this call are spending, or about half are spending at least half of their time supporting the mental health needs of these students. And then to what extent do you feel that the mental health of students with IDD is overlooked or missed? And most of you are saying about half to a majority of the time. All right. So let's dive in. So I want to start off by just really diving in and talking about what does it mean to have an intellectual and developmental disability, or IDD. And this is a broad term. And when we say IDD, what we're saying is that these are disorders that are usually present at birth and that uniquely affect the trajectory of the physical, the intellectual, and or the emotional development of someone. And I think the important thing to know is that even though IDDs are typically present at birth, it may be the case that symptoms or signs that someone has an IDD don't show up until later in childhood. And so that is certainly something that we see. Many of these conditions affect multiple body parts or systems. And what that means is just, I think as educators and clinicians, we often think about the learning profile of our students, and certainly IDDs affect how students learn and their ability to participate in different classroom activities and educational activities. But we're also thinking about how IDDs affect things like the sensory system, the motor system, communication systems. And so typically what we see is that, yes, certainly IDD impacts learning, but we also see it impact other areas of development. And so really IDD is the umbrella term that's used to describe when someone has an intellectual disability and or some other kind of developmental disability. And I'll talk about this on the next slide. So an intellectual disability is first, and that really starts again before in childhood. So by the time someone turns 18. And strictly speaking, it's characterized by difficulties in intellectual functioning or intelligence, which includes things like someone's ability to reason and problem solve, to learn new information and to remember new information. And in addition to that, we also see difficulties in what we call adaptive behavior, or someone's daily living skills. And so that's their ability to participate in meaningful home routines, right? To do things like brush their teeth, run errands, take out the trash, and also in social routines too. So ability to kind of make friends and participate in other extracurricular activities. So to have an intellectual disability, we're really looking for difficulty in both of these areas, and significantly so. And so this is typically assessed using both standardized measures of intellectual functioning or cognitive skills, as well as adaptive functioning, usually through caregiver report. A developmental disability is a broader category that's also often lifelong and can be intellectual, physical, or both. And so an example of this might be autism spectrum disorder, which is a developmental disability that may or may not include the person having an intellectual disability. So a person with autism has differences that are present from birth, and that may or may not impact their ability to learn and their intellectual functioning. So again, I do think of IDD as an umbrella term, and Sarah Trello posted in the chat a link to the American Association for Intellectual and Developmental Disabilities. This is a fantastic resource that provides both information on IDD, commonly used resources related to identification and services, research, and other kind of journals and articles. But again, we're thinking about an umbrella term, and under the umbrella of IDD fall things like autism spectrum disorder, genetic syndromes like Fragile X syndrome and Down syndrome, cerebral palsy, which impacts motor development and is also associated with developmental delays, as well as intellectual disability. So all of these may fall under IDD. What I don't love about the visual on this slide is that it somewhat misses the fact that some of these things can go together, right? So like I mentioned, a person can have Down syndrome and they can have an intellectual disability. A person can have Fragile X syndrome and also autism spectrum disorder. And so under this umbrella are some of these distinct categories, but they also sometimes go together. When we think of prevalence rates of the kind of categories that are listed on this slide, we see the highest prevalence rates of autism spectrum disorder and intellectual disability. The prevalence rate for other things like Fragile X syndrome is relatively low. So we're thinking about 1 in 7,000 youth. So I do want to hone in on autism spectrum disorder in part because it is one of the more prevalent IDDs. And there's a lot of research to demonstrate both, obviously to characterize autism and tell us what it looks like across the lifespan, but a whole lot of research to also show that autism spectrum disorder co-occurs or goes along with mental health challenges at a very high rate, much higher than we would see in the general population. And so I'm going to pull from that research today. Much of what I talk about for ASD is prevalent in other IDDs as well, but I want to get concrete. So when I talk about ASD today, we'll be thinking about specifically first what is ASD, and it is characterized by deficits or difficulty in social communication. That's one aspect of ASD, and also restricted and repetitive patterns of behavior. Again, this is a neurodevelopmental disability, so we expect that symptoms are present very early on in the first 5 years of life. When we think about social communication and social communication difficulties in ASD, this can look quite different across a person's lifespan, but really we're broadly thinking of difficulty with nonverbal communication, and that can take the form, most often, I think, stereotypically, we think of eye contact, but it can also be in the use of gestures and other nonverbal communication. Difficulty with what we would call reciprocal interaction, so back and forth interaction. When students are older, this can look like difficulty with conversation, so that give and take in social interaction is a little bit harder. Difficulty forming relationships and friendships, and then also difficulty with perspective taking, which is related to nonverbal communication, right? So having a hard time reading someone else and reading kind of the emotional cues or nonverbal cues that they're giving you. So when we're looking at ASD, we think about social communication as one piece. And then we're also looking to see, does a student have kind of these restricted and repetitive patterns of behavior? And this looks like, take different forms, but it can look like special interests. So these are interests that are more specific and or more intense than we might expect of someone. So maybe it's a very strong interest in cars or in airplane flight schedules, right? And so these interests often are narrow and time consuming and really can take away from social interaction. We may see sensory differences, and so this can be both an overactive sensory system or an underactive sensory system. So being overly sensitive to things like light or smell or taste, or being undersensitive, right? Having a very high pain tolerance or not showing pain. Black and white thinking, which we'll come back to today when we think about mental health. And so this is this very kind of, at times, rigid way of viewing the world. And so difficulty kind of shifting perspectives, difficulty making transitions. And so that we see a fair amount. And then the final piece is repetitive behaviors. And so this can, again, look like different things. It could be repetitive motor movements. So repetitive clapping or repetitive rocking, for example, but it also can be repetitive communication too. So we might hear someone use a specific phrase that maybe they heard in a movie, and they may use something like that quite frequently. I think one just important thing to know, especially as we transition into this next slide, is that in order for both in schools, so from an educational standpoint and also from a medical standpoint, when we think about identifying or making a label or a diagnosis, if you will, of autism, we're really thinking, do these symptoms get in the way, right? Do they make someone's life hard? And that is ultimately always kind of what we're trying to understand. Recently there's been an expansion, like prior to 2013, there used to be categories of autism. So you had Asperger's syndrome, you had autistic disorder, and you had pervasive developmental disorder. In 2013, the American Psychological Association grouped all of those categories together. And so they now fall under, autism spectrum disorder. And so, a common question that we hear is, well, what is the spectrum? And, I think it's a tricky question. The way that it's currently conceptualized by the American Psychological Association is probably overly simplistic, but I think that this slide breaks down how they're viewing the spectrum. And so really we're thinking about how much does someone's symptoms of autism get in the way or make it hard. And we think about level 1, if you will, being that someone still needs support for social interactions, right? And they may need support to make transitions. But within a school setting, they're able to be in the general education setting with minimal support, right? They may get pull out for social skills. They may get pull out for maybe academics, but for the most part, they're doing pretty well. Level 2, we're needing a little bit more support, so needing moderate support for social interaction. And repetitive behaviors may be more impairing or get in the way more. And so oftentimes here, a student may be in the general education setting for a period of time, or they may be in the general education setting, but receiving support from a paraprofessional or someone to make sure that they're able to learn and engage and do well. And then level 3 is what we think about as being when autism really gets in the way and really makes life a little bit harder. And so these are students who may need significant support for social interaction and communication. Restricted interest and difficulty a transition are pronounced, right? And so when a student's making a transition, that might be so hard that it results in a meltdown, right? Or kind of challenging behavior, right? These are symptoms that really do get in the way. And usually for these students, we're thinking maybe they might need specialized support. So within a classroom that might be separate from the general education setting, but that is able to provide more kind of intensive services and supports. In general, I've already shared ASD is we've seen the prevalence actually increase significantly since the 1990s. It used to be, prevalence rates were estimated at about 1 in 150. And now as of the last year, they're estimated to be about 1 in 54. And that increase in prevalence is due to a lot of things, but is important to know. And the other thing, obviously, to know is that the male to female ratio is, we see that we see a higher prevalence of autism in males, also potentially due for lots of reasons. And I will say we are getting better at identifying women and girls who may be on the autism spectrum, but we still see that ratio. And importantly, when we think of ASD, oftentimes we say, for these individuals, we're going to need individualized and therapeutic supports across the lifespan for most people. Now, what those therapeutic services look like at a given age may differ, right? The services that someone needs when they're 3 or 4 are obviously going to be different than when they're 10 or 18 or 30. But oftentimes support is needed across the lifespan in different capacities. But that's easier said than done, right? I think as a clinician who works very closely with families, I think it's easy to say what best practice is at different points in a person's life or to recommend services. But it's not always easy to access those services, right? And so, especially within community settings, we think about, are people on long wait lists? They certainly are to receive services. Some services require a medical identification of autism, right? In order for insurance to cover it. Now that poses many challenges. And so we do have issues with the timing of treatment. And then once people are able to access treatment, that doesn't necessarily mean they're able to access the quantity or the dosage, right? That might be best for them for all sorts of reasons, both availability, but also thinking back to insurance coverage and the cost of different services. And then finally, we think about treatment quality, right? And so across states and counties and cities and even neighborhoods, there's really significant variability in what services are accessible to families and whether those services are truly kind of evidence-based or best practice, meaning that we know that they're going to support or they're likely going to support a child and a family. I will say, it's not on this slide, but just one thing that I think is still shown in research is that when we think of that umbrella of IDD, one of the things that we see is that for families of a child with autism, oftentimes they report more unmet service needs than families of children with other developmental disabilities, right? And so although unmet needs are certainly prevalent across people with IDD and autism, they appear to be particularly notable. So, right, so schools are really ideal when we think about treatment access. And this is something that I think you all are aware of. So I don't know that I need to necessarily say this, but as someone who primarily practices in a specialized clinic, schools are ideal, right? Over half of students in general receive mental health services in school. And we know that students with IDD are more likely to be receiving formal services through an individualized education plan, right? And so what's unique about this population is that many of them, not all, but many, are already accessing services in schools. And so schools really do serve as a natural gateway to receiving either whether it be mental health or other services that may be difficult to access in the community. And so we often say, right, if we can deliver mental health programming in schools, we're able to remove some of the barriers, maybe not all, but some that families experience when they're attempting to access services in the community. So things like insurance and time off of work and cost of care and needing to find babysitters for siblings. So it really is kind of an ideal access point for these students. All right, so I'm going to pause here, and we are about to make a transition to really dive into mental health, specifically for IDD and autism. And before we do, I have just one polling question that's going to ask you about the kind of availability or perceived availability of mental health services, specifically for students with IDD at the schools that you're at or in the settings that you're at. Awesome. So I'm gonna end this poll. I'm just going to share the results back with you. And then I see a few comments in the chat box that I want to make sure that I address. So again, the question here is mental health services for students with IDD within our schools are. And a good majority of you are saying they're available, but difficult to access. For some of you, they are readily available. For very few, they're not available at all. But I think this last box speaks to comments in the chat box, which is, what might it take to kind of get students connected with these services? So Fran is saying, I'm super interested in learning what school staff/educators feel they need to get students and families connected to community supports, better understanding what's out there regarding services, ? So we'll talk a little bit about that today. So where does that gap happen, right? Where's the miss in making some of those referrals? And I do think, having worked in schools prior to coming to Georgia, I can't speak to the Southeast region, that some of it is knowledge. I think some of it also too is truly can be availability, right? One of the things that we see, not all the time, but often, is that clinicians in the community and even in schools too, who are mental health experts, right, may not necessarily have the expertise of working with someone with IDD, and vice versa, right? Therapists who predominantly work with students with IDD, whether they be a behavioral therapist or a speech language pathologist, may not necessarily have the mental health expertise to support a student with ASD. And so sometimes there is a mismatch in those knowledge bases, which makes people hesitant to serve the needs of the mental health needs of students. And some other really important comments. I agree, it is more difficult to access services when schools are not located in urban areas. Absolutely. Those services are difficult to access as it is. Now, obviously, the move to telehealth has made some things easier when we think about families from rural areas accessing services, but it tends to be the case that families who live in more rural communities have have more difficulty accessing services. And then, yes, some of this might depend on the mental health services you are considering, certainly. Differences between, for example, seeing a psychologist or social worker or counselor and seeing a psychiatrist, for example, for medication management. Oftentimes, it is more difficult to access something like psychiatric services or medication management. So to transition into the mental health challenges seen in students with autism. So what this slide depicts, and I realize there's a lot going on, but on the x-axis, you see groups of different mental health conditions, right? So you have ADHD, anxiety, depression, bipolar disorder, etc. And on the y-axis is kind of the percent of youth with autism who have that mental health condition also. And the different colors represent just different studies that have been done that have given us estimates, right? And so you'll see, for example, for ADHD, across 4 studies, we see that about 20 to 50% of youth with autism also experience ADHD. There's a lot of variability, right? Even within something like anxiety. And in part, that depends on how the mental health condition was assessed, right? So anxiety, for example, we might see higher prevalence rates if it's just based off of something like parent report. But we might see lower prevalence rates if it's based off of parent report and child report or teacher report. And so some of that variability depends on how the condition was assessed. This is a summary of that crazy graph. And so what this graph shows is both, what is the average prevalence of each of these mental health categories in autism, and how does that prevalence compare to youth in the general population? And I think this is really important because what we often see is that students who have autism are more likely, significantly more likely, to experience a variety of mental health conditions, including ADHD, anxiety, depression, bipolar disorder, and schizophrenia. Oops. For today, as we move on, I am going to hone in specifically on anxiety, in part because it's one of the more prevalent co-occurring mental health conditions in autism, and also can be highly interfering. And so for this specifically, once we get to it, we see that about 20%, so 1 in 5 students who have autism also experience anxiety in comparison to about 7% of youth in the general population.
I've tried to stop understanding, like,
Um, so why is this the case? I think this is really important to talk about. It's a common question that we get, and I think a valid question, which is, again, what makes these students more vulnerable? And there's a lot of reasons. There's not just one. And on this slide and the next one, I list some of the reasons that we think are most likely. One being that, there may be this is wordy, but shared biological etiologies with psychiatric illnesses. And essentially what that means is just that students with autism may have some biological differences that make them more at risk for things like anxiety and depression. So for example, differences in their ability to regulate their emotions, right? Emotion regulation is hard in many students with autism, and that also places them at risk to have these mental health differences. Another reason is discrimination, victimization, and segregation, right? So historically, students with IDD have been segregated. They're much more likely to experience bullying, teasing, and peer rejection at school. And those events certainly place them at risk for anxiety and depression and other mental health challenges. Co-occurring medical conditions. So for example, one of the things that we know about autism for specifically, but other IDDs too, is that students with autism are at an increased risk to have, for example, seizure disorders. And those co-occurring medical difficulties can be scary and also can make life harder. And so those things as well may place students at greater risk to develop mental health challenges. These last two are important. The first is that, we saw the high on the previous slide, the high co-occurrence, if you will, of ADHD and autism. Many students with autism have difficulty with executive functioning, so with planning and organization. And that is stressful. It's stressful, especially within a school context, right? If you can't remember where your homework is, or it has been lost, or you have forgotten what it was that you're supposed to do, or you didn't hear what was told of you, right? The instructions. That is stressful and certainly can make it hard or make someone more susceptible to these things. And then finally, lack of social understanding or theory of mind. And so we already talked about it being difficult to read social situations. Well, school and making friends is hard enough as it is. Making friends is even harder when it's hard to figure out what the heck is going on. And so when we think about anxiety, especially, right, the difficulty reading social cues and fitting in with peers is certainly something that may contribute to social anxiety. And then just a few others that I want to hit on briefly. We also think about differences in temperament. We talked about individuals with autism being more kind of rigid and having more black and white thinking. That may make them more susceptible to ruminate and to get stuck on either situations that are scary or negative situations when they're bullied. Cognitive vulnerabilities, we've already talked about. Trauma and negative life events. We know that people with IDD are more likely to experience trauma or early childhood ACEs. Those certainly place them at risk. And then finally, parenting, both style and parenting anxiety can play a role. As a parent, can be anxiety provoking to have a child who has developmental differences. And so, that, how parents parent or how parents support their child with IDD can impact the development of different psychiatric conditions. So a lot to think about. Those slides I think are, there's a lot on them. I think the take home is that, there's a lot that places these students at risk. And I think a lot of them, although in some ways that, they make sense and there's certainly things that we see, I think it is helpful to list them out to really show that this particular population really does experience a lot that puts them at risk for these things. But I do want to talk briefly about emotion regulation. I referenced this a couple of slides ago, but when we think about mental health challenges, we think about emotion regulation as really being at the heart of a lot of difficulties. And so when we say emotion regulation, or when I say it, really just talking about the ability to recognize your own emotions, which is important, but also to manage your emotions in relationship to lots of different situations. So it could be managing anxiety. It could be managing negative emotions. It could also be managing excitement too. So I think we often think about managing negative emotions, but it can be regulating your positive ones as well. We know again that students with autism have difficulty with emotion regulation. And so it is a risk factor that underlies mental health symptoms. I like this slide because it just depicts that specific situation, which is that, when we think about mental health, right, emotion regulation really is at the foundation. And those difficulties contribute to things like irritability, to anger, to depression, to anxiety. And what does anxiety and depression and anger look like? It can look like problem behavior, right? So it can look like non-compliance. It could look like elopement, running out of the classroom. It could look like aggression, whether that be verbal or physical or both. And it could also look like self-injury, right? So getting really frustrated and hitting yourself or banging your head. And the reason I say that is because, as a clinician and as a parent and as a teacher, oftentimes what we see first is problem behavior, right? So we see the non-compliance, we see the self-injury, and those things really do get in the way. Those things can be difficult to manage. And so, I think anytime we see these behaviors, it's taking a step back and really trying to understand why, right? Obviously, there are many reasons, for why behavior happens, but to have mental health on our radar, right? Some of these behaviors may not necessarily be naughty, right? Not all of them are naughty behaviors or behavior to, intentionally hurt someone, but may reflect actually underlying mental health challenges. So when we think about, right, identifying mental health and what might make it challenging in students with IDD, there are a few different reasons. One is what we just talked about, and I'm going to explain these on the next slide, problem behavior. We're also going to talk about something called diagnostic overshadowing, psychosocial masking, overlap in diagnoses, and then just the fact that some mental health symptoms look a little different in autism and in IDD. Okay, so problem behaviors, we already talked about this, right? Aggression, self-injury, or other difficult behaviors are seen as naughty behavior rather than mental health challenges. And so, for the kid who runs out of the classroom, right? Well, why are they running out of the classroom, right? Is it because they're, in a situation that is anxiety provoking, or is it to escape something? It's important to understand why. Diagnostic overshadowing. So this is when symptoms of anxiety and other mental health challenges are seen as being autism, right? Only autism and IDD and not mental health. So for example, when a student is not is kind of isolating themselves from a social situation. I think it's easy to say, well, that's just the autism, right? They don't like peers. When it could be that, yes, it's the autism, but it's also social anxiety, right? It's also being nervous to interact with peers. Diagnostic overlap. So this is maybe so similar. So shutting down or not talking to peers is a symptom of autism and also a symptom of social anxiety. And then psychosocial masking, this is just a fancy way of saying that students may be able to hide their anxiety or mental health challenges at school due to not wanting to appear different. And so we see this certainly in older students and teens, and we see this in the general population too, right? And so it may be hard to see mental health challenges if students are actually hiding them to try to fit in. And then finally, and I think important, is that some symptoms may actually look different in students with autism, right? So anxiety may look and show up as an increase in autism symptoms, right? So you may see a student who typically rocks or flaps, maybe they're doing that more, right? And that is, yes, a symptom of autism, but also the reason we're seeing that increase is because of anxiety or depression or something else going on. So I want to dive in and just chat a little bit about anxiety. I think, again, the challenge with mental health, to someone's comment in the chat box, is that mental health is very broad and includes a lot of different things. So I want to hone in on anxiety and just talk about what it is and what it can look like at school and in students who have autism or IDD. So when we think about anxiety, we're thinking about fear, right? So that might be that physiological startle. We think about anxiety, think about worry that is excessive and persistent, right? We all get worried, anxious, fearful. That's a adaptive response, right? But when worry sticks around and it stops you from doing things, that's when we think about it being a disorder. And so, we really try and support, parents and students in understanding that not all anxiety is bad. But when it starts to get in the way and is excessive, that's when it can really, really be hard. In the general population, we typically think about symptoms of anxiety as falling in different categories. So physiological symptoms of anxiety, these might be things like rapid heart rate, shaking, anxious facial expressions, crying, sleeping or eating disturbances. So really changes in how your body feels or what your body shows. You also see cognitive symptoms, right? And so this cognitive distortion, so blowing things way out of proportion. This is going to be the worst test or worst assembly in the world. Negative self-talk, rumination, worry, and anticipating that bad things will happen. So those are also symptoms of anxiety. And those result, right, like we've already talked about, in behavioral symptoms, right? So you may see avoidance or withdrawal, not wanting to do certain things. So really trying to remove yourself from situations that might make you feel a little worried. And then on the flip side, we sometimes see reassurance seeking. So lots of questions around, am I going to do okay? Is it going to be hard? What's going to happen? Those are other common signs. Common categories of anxiety in the general population are specific worries or fears of animals, the bugs, doctors, the dark. Separation anxiety, right? Although that is normative early in childhood, we do see separation anxiety that gets in the way as kids get older. Social worries are quite common. So worrying what other people might think of you, worried about being teased. And then there's the chronic worriers, right? So worrying about all the things, right? Whether it be school performance, what's going to happen tomorrow, fear of death, the future. And so we see chronic worries as well. But I want to, right, the goal is to really talk about what this may look like in ASD and IDD. And so obviously all of those symptoms and all of those categories certainly apply in autism, right? And so you see similar social worries and fear of the dark and separation anxiety. But we also see some additional distinct worries in ASD and IDD. And so some of those idiosyncratic fears that we see most often are I guess I shouldn't say most often because sometimes they feel a bit random, but things like being terrified of fans or the television or people who look different or, random cartoon characters. So we do see things like this. Fear of change, right? Change is hard. And so sometimes we see that kids get very nervous about even the idea that there might be change. Like if there's a substitute teacher, that worries them quite a bit. We see fear about certain sensory experiences, right? These students are more susceptible to having sensory differences. And that's scary, right? Fire alarms, although they're loud and scary to begin with, for students with autism, right? Though that sound is overwhelming, right? And so we see intense worry related to things like that. Fear in social situations, and then also worry about not being able to do a special interest. So, if you're extremely interested in, for example, I don't know, tracking flight schedules, right? You may be worried about whether or not you're actually going to be able to do that, right? Or to actually check in and see what flight schedules look like. So we conducted this was in Colorado. So prior to being in Georgia, I worked a fair amount in the public school system in Colorado. And through that work, we were very curious to see, what is it that anxiety actually looks like in schools, right? Because a lot of the research that we have is specific to what does anxiety and mental health look like at home or in the community, very, very rarely in school. And so we asked parents and we asked teachers and educators, how do you know, like when your students with ASD or IDD have anxiety? And so some of the things that they said, which I think is just really interesting, is refusing to do things, not wanting to go to school. So school refusal being a huge thing reported by parents, being clingy, going nonverbal. And so that reference to shutting down in class and being quiet as being a common symptom of anxiety. Flying under the radar, right? So, not really looking too different, but ultimately still experiencing anxiety. So reference to this difficulty, seeing it sometimes. Getting stuck in a loop. So sometimes, we'll see that kids just get more rigid, right? Or they get more stuck. They ruminate more on difficult situations. And then reference also to some of the kind of aggression and challenging behavior that we've talked about previously. So we'll get tough and say threatening things is what one parent said. So again, some of these things might, say, oh yeah, like for sure, shutting down, going nonverbal, definitely kind of anxiety. But other things maybe, I don't know, may not be as obvious. We also asked school providers and teachers. So these were school psychologists, counselors, social workers, and teachers. How do you know when your students with ASD or IDD, how do you know when they're anxious? And so they said things like attendance issues and tardies. So similar to what parents said, right? Like kids are having trouble just making it in the classroom, getting in the door to school. Hiding under desks or leaving the class. So again, that reference to just like physically leaving the situation because fear is high or the situation is too anxiety provoking. Perfectionism. So not wanting to make mistakes, tearing up a paper because there's a mistake, spelling error on it, disrupting class, instigating peer conflict, and just a general lack of confidence. Those are what we heard most often from teachers. And I just, I think I appreciated this because, oftentimes when we think anxiety, we think some of the quieter, more subdued kind of shut down behaviors. And I think what this shows is, again, absolutely those may be the case, but we also see other symptoms as well. And these symptoms, right, get in the way of school a whole lot. And so we see when students have anxiety, or students with ASD have anxiety, again, we're seeing school refusal, which looks like absences and tardies. We see more autism symptoms, so being less engaged or having more repetitive behaviors. Reduced extracurricular participation, right? Students are opting out of situations where they would get to be around peers. Lots of trips to the nurse's office. That was something that didn't necessarily come up with parents and teachers, but we see a fair amount. So stomach ache, headache, getting out of things. And then avoidance, which we've already talked about. So I want to pause. That was a lot of information about autism and different mental health challenges. And just want to take the time to really hear from you and ask, what it looks like, or what might make it difficult to kind of identify anxiety in students with IDD. So the question is, for me, identifying the signs of anxiety and other mental health challenges in students with IDD is difficult because, and we have some different options here. And then second question is, in students with IDD, anxiety most often shows up in our schools. So I'm just curious, what was shared a whole lot on, different symptoms, but want to hear what you all see. All right, I'm going to close the poll here in a few seconds, and I'll just share out just so you can see what other people are saying with regard to some of those difficulties, and then some of the symptoms that you all are commonly seeing. All right, so for the first question, that really is about, what makes it difficult to identify anxiety. So some folks are saying limited professional training, but the most kind of often endorsed responses are the student has other needs that are more pressing, behavior or learning. Absolutely, right? I do think that makes it a challenge, right? When there's, especially when there's behavior. Or misinterpreting behavior, right? I do, like we've talked about, staff shortages. And students with IDD, here's what folks are saying anxiety looks like: refusing to come to school, challenging behavior, disruptive behavior being common, and some of these other things. If there are symptoms, right? I mean, the poll itself is limited by the response, the response options that were put in them. And so if there are things that you see, right, that are not reflected in this poll, please do share them in the chat. I would love to hear how anxiety and mental health is showing up in the different settings that you're in. All right. So in part 2 of this webinar, we're going to be honing in on, okay, right, I think we can get on the same page and and recognize that this is an important need in these students. And we'll be transitioning to talk about, okay, so what does it actually look like to support the mental health needs of students with IDD in schools? But again, the top reasons to treat anxiety in schools is that, again, anxiety is common in students with IDD. We already talked about those prevalence rates. It certainly gets in the way of school performance, and it places students at risk for academic, social, and emotional problems, and gets in the way of friendships and extracurriculars. It's also ideal to treat anxiety in schools, right? I mean, I think one of the things that we're hearing is that anxiety gets in the way, right? It shows up in school. And so why not treat it in the settings in which it shows up? Oftentimes that makes the biggest difference. So next week, we'll be talking specifically about what is considered best practice in the treatment of anxiety in students with IDD, and we'll be honing in and talking about cognitive behavior therapy, which is a type of structured therapy that supports students in identifying their emotions, learning strategies to calm their body, so relaxation strategies, learning to use helpful thoughts, and then taking those skills that they've learned and actually applying them to situations that start off maybe a little bit fear, a little bit scary, and then build from there. So facing their fears a little bit at a time. And then again, we've already talked about this, but schools are ideal because access to treatment is hard. It's harder in certain community settings than in others. But in general, my experience has been that accessing mental health services for students with IDD in the community can be quite difficult. And so schools, again, are already serving these students, already providing mental health care. How can we think about bridging evidence-based practices into those settings? Just to wrap up today, I just, again, it's one thing to talk about all of these things and kind of the abstract. But what I wanted to do is just do 2 quick case studies. And really the case studies are designed to show exactly what it might look like. Again, there's a ton of variability, but exactly what it might look like if a student with ASD or IDD had a mental health difficulty. And so I'll just have a couple of questions for each of these case studies. So you'll see a poll jump up here in a second. But the first case study is that Darnell is in the 5th grade. He received a diagnosis of autism when he was 3 and received an IEP at that time. His social skills have improved significantly. However, he's still qualified for an IEP under the identification of autism. He has one friend who he shares his interest in cars and video games with. Darnell participates in general education. He does well, but he does not like group work and is quick to correct others if they don't follow the rules of the project. Peers are starting to make fun of him and call him the rules police. And when there is a group project, he is now saying, I don't want to do it, or goes to the nurses and complains of a stomach ache. This is happening daily. He has a huge problem in PE and recess and has shared that he hates losing, not getting picked for a team, or having people watch him do a sport that he is not good at. He is now protesting going to both activities and asked to go to the library instead to read about cars. His school team is wondering if anxiety is at play and if treatment is needed. And so just a couple of quick questions just to get your thoughts on this specific student. I think the polling questions should go up. There they are. So what behavior cued you in to the mental health need? So what signaled to you that Darnell might be having a mental health difficulty or anxiety? And then the second question is, why might the mental health need of Darnell go missed? Like what might get in the way of identifying it for him? All right, I am gonna end that poll and just share it back with you. Yeah, I think disengagement, right? So not wanting to do things, right? Not wanting to go to PE, not wanting to participate in group projects, trying to get out of them, right? So that elopement, not necessarily elopement, but going to the nurse's office. All of those things are valid cues. And then what might get in the way, lots of things you're saying, but including misinterpreting the behavior, followed by other student needs being more pressing. So maybe the behavior, there's other behaviors at play or other learning needs that are more significant. All right, I'm gonna exit out of this. We just have one more here, and then want to wrap up and open it up for questions. So in this case study here, Sam is an 11-year-old boy who was adopted from Kyrgyzstan at the age of 4 by a single mother. He was severely neglected prior to that time, living in 3 different orphanages. He was later diagnosed with autism. After 1 or 2 difficult years adapting to life in the US and receiving trauma-informed therapy, he and his adoptive mother now have a very tight connection. Sam's mother reported that although behavior difficulties have improved over time, Sam continues to have meltdowns at school during drop-off. He also appears worried if his mother does not arrive to pick him up from school exactly on time, and has asked his teacher, "Do you think my mom was in a car accident?" The last hour of the school day is very difficult for him to get work done. During this time, he often asks his teachers if his mother will be on time. He frequently experiences physical complaints, and often appears distracted during work. Classroom performance is poor. So same questions here again, just what might cue you into the mental health need, and then what might get in the way for identifying the mental health that Sam's experiencing. All right, I'm just gonna share that back really quickly. And again, some similar responses here. School refusal, well, not school refusal, challenging behavior, crying, shutting down. A lot of you said other, or some handful of you said other. If there are other things that cued you in, please feel free to use the chat box. Again, these polls do not by any means capture the only ways that anxiety and these challenges show up. And then why might the mental health needs get missed in SAM? And similar responses, right? You know, there could be misinterpreting behavior. His needs in other areas may be more pressing. And one thing that came up is also professional training. So how do you actually kind of identify and support SAM? Yeah, I mean, I think absolutely. So in the chat box, yes, difficulty with transition, thinking those close to him have died, history of separation anxiety, absolutely, right? This is not a new concern for Sam. It has followed him. Obsessive thoughts, yep, getting stuck, ruminating, if you will, on the fact that his mom might not be there. And also, yes, attachment issues. So all that to say, right, you know, mental health and anxiety challenges are quite common in this population. I do think, you know, there's a number of reasons that make them tricky to identify, especially when challenging behaviors are at play. But my hope is that the take home of this talk is that they are present. And anytime we see behavior, right, you know, it is important to take a step back and think about whether mental health might be part of the picture. It is not always, but sometimes it is. And to really be thinking about how can we support the mental health of these students, knowing that they are so vulnerable. And so next week, in part 2 of this webinar series, we'll be really basically spending the vast majority of the talk talking about, okay, what does it mean to support these students? So specifically to describe the evidence-based approaches to support the mental health students of IDDs, to think about or weigh different ways that mental health programming can be delivered in schools. So I think it's one thing to talk about best practice, another thing to think about, okay, what does best practice actually look like in schools? And we'll be polling a case study for that specific discussion on how mental health programs were implemented in schools. And then objective 3 and 4, to plan for successful and sustainable mental health programming and to know where to find additional resources to address the mental health challenges of students with IDD. So some of those will be in the next talk. And I do want to just, again, reference that earlier in the talk, the link to the American Association for Intellectual and Developmental Disabilities was popped in the chat. And that is a fantastic resource broadly for IDD, but it also has resources that are specific to the mental health needs of those students, including archived webinars on mental health. And just want to say thank you again for being at the webinar today, for your questions and comments in the chat box. There's some additional information here on MHTTC, the Southeast MHTTC, and then my email and is probably the best way to contact me, and website is also there. So be happy to take additional questions in the chat box, or if there are additional comments for the group, feel free to put those in now. Oh, I was reminded that there is one final poll, which I must have missed. So I think that may be launched here in a second. Yes, and I can absolutely provide the article on that research in Colorado. So some of the slides that we showed today were snippets or snapshots of the work that we did in Colorado, and I'll talk a lot more about that in part 2. That was across a number of different public school districts, and I will make sure that that gets sent out. So the final polling questions for students with IDDs, mental health topics that I would like more information on are, and for the topics I've identified in the previous question, I would want more information related to. So some specific options there. And this will be helpful just in thinking and planning for future talks, but also for kind of additional resources that we can provide to folks on mental health and IDD.
Again, we encourage you to either use the chat box or come on camera or turn off your mute button and ask Dr. Pickard any questions that you might have.
And thank you for those of you who have voted in this final poll. I'm going to keep it open just so everyone gets the opportunity to weigh in on what information would be most useful for them moving forward, but just to share out, for students with IDD right now about, the poll asks you, what are topics you would like to learn more information about. 82% of people right now are saying supporting emotion regulation, which will be part of what we talk about next week. It is part of best practice when we think about this group: supporting challenging behavior, trauma-informed care, and supporting executive functioning, and supporting anxiety, actually. Basically, all topics have responses that are more than 60% of people saying it'd be useful information. And then for polling question 2, for the topics that you have identified, folks are saying that it would be most useful to have informal strategies to support these different mental health conditions. So 71% of folks are saying strategies would be useful. About 60% are saying formal treatment options. And half of people are saying really thinking about specifying and allocating school resources for these issues. All right, so it looks like almost everyone has voted, so I'm going to end the poll. References are here. I will make sure that those articles are sent so that y'all can access them.
Thank you so much, Catherine, and thank you to everyone who participated by being here and asking questions and sharing about yourself in the chat, and for participating in our polls. So you can keep in touch with us. Sarah will plop those links into the chat box on the Southeast MHATC website, where you can see our upcoming events, our products, and our resources. And then the second link there is our listserv. So make sure you click on the school-based mental health tab to follow school-focused resources and events. And then finally, the last 2 links are our social media. You can follow us on Facebook and Twitter. Again, just another way to get informed about what events and resources we have. And next slide, please. So it is super important to fill out this brief survey. As part of receiving SAMHSA funding, we are required to submit data related to the quality of this event. And we ask that you please take a moment to complete this brief survey about today's session. And after you complete the survey, you'll be redirected to a second survey that includes additional information our center likes to collect to continue to improve the quality of our trainings and to make sure that we're addressing the needs of our stakeholders, you, in Region 4 through our programming. We greatly appreciate it. So please take this opportunity to complete the second survey as well. And thanks again, everyone, and Catherine for a great presentation.
Thank you, everyone. I really appreciate it.